Good afternoon to everybody, and welcome to the session number 4 of Click on Air. I personally want to thank George Adams to join us during this session, together with Mariano, Palena, and Andrea Casini. The session is completely recorded, so we do not have live cases anymore in this session, but will be, I think, capable to stimulate a huge discussion with participants and with attendees, because we will treat the problem of the calcium. The question is, does calcium matter? And so we start immediately with George, because we have to change a little bit the program. And welcome, George. We are waiting for your case. Thank you very much.
Thanks.
To everybody. We are here.
Thank you. Thank you, Marco. So I'm going to share my screen. So it's a pleasure to be here. So let's see here. Can y'all see my screen?
Yeah, we can see it. Perfect.
Great. So we're going to discuss the treatment of calcified lower extremity disease with intravascular lithotripsy. These are my disclosures, which aren't relevant. Remember that intravascular lithotripsy has been around for years. In fact, the safety of it has been shown very eloquently in the urologic space in kidney stone treatment. Now we've extrapolated this device to cardiovascular causes, right? So literally, intravascular lithotripsy is emitters on a balloon, as you can see here to your right, used to crack that hard calcium, which has been the Achilles heel of most of our peripheral and coronary interventions. When we actually look at the device, it's pretty simple. So there's a compact rechargeable generator that actually comes on a pole, the connector cable, which connects to the catheter. And as you can see to the left, a focus of the catheter shows the balloon with the emitters that actually goes across the lesion. There are two types of catheters. One's above the knee, the Shockwave M5 device. It can treat a host of diameters from 3.5 to 7 millimeters. Depending on the diameter balloon size, will determine whether you use the 6-French or the 7-French sheath. All of them go over an 014 wire platform. Below the knee is the S4 device and goes to a 5-French sheath and treats a vessel diameter of 2.5 to 4 millimeters. When we actually look at the device working, as you can see, the generator sends through the catheter to the balloon the sonic pressure waves, which are given off through the emitters. You take the balloon up to low atmospheres, 4 to 6 millimeters max, did not cause bear trauma, just to get apposition of the balloon to the vessel wall, such that you can give these sonic pressure waves, which is an effective pressure of about 50 atmospheres. It affects both intimal and medial calcium, so you don't get those spiral dissections and elastic recoil. In terms of looking at how this works, let me click this as a talk. There's unfocused lithotripsy energy. It's safely emitted. There's a balloon. It actually emits through the fluid in the balloon. We're careful to make sure that we bring each one of the balloons down between each session of giving the ultrasonic device, so it doesn't decrease the efficacy of the energy delivered. As you can see, the bubble expands, collapses, and you get these sonic pressure waves. When we look at OCT, it demonstrates this calcium disruption, both intimal, and we'll discuss medial in a minute, both in the peripheral and coronary arteries. When we look at the applications of IVL, there's a whole host of applications, both with calcific and heterogeneous plaque, both in the peripheral and coronary space. And in terms of the vessels treated, a whole host of peripheral and coronary. And then in terms of the strategy, it can be a standalone therapy. It could be for vessel prep, an alternative to surgery, and for transfemoral access, especially with these structural heart valves, which have come to fruition recently. When we look at the clinical evidence, it crosses all spans, and there's a host of clinical evidence. When we look at the target lesions, there's SFAs, popliteals, infrapopliteal, below the knee, common femoral arteries, iliac disease, as well as coronary arteries. We've used this in pre-TAVR, especially in the iliac realm and the common femoral artery realm, so we can place these larger sheaths. When we look at the different applications, again, we've discussed many of these already, but again, above the knee, below the knee, for those regions that we've typically not treated in the past, these have been taboo and reserved for surgery, such as common femoral artery and popliteals, as well as for transfemoral access for these larger sheaths for TAVR and et cetera. When we focus in on critical limb ischemia, remember the epidemics of the comorbidities, not just in the United States, but around the world. People are getting older. Diabetes, at least in the US, 1 out of every 4 Americans over the age of 65 have diabetes. And the number one cause of renal insufficiency is diabetes. What this leads to when you combine all these comorbidities is multi-level calcific chronic total occlusions that leads to critical limb ischemia. So we need effective therapies to treat this type of population. When we focus on below the knee disease, we know that there's a prevalence of calcium. The thing is, with these lesions below the knee, typically they're occlusions, they're long lesions and have extensive calcifications. The issue is that plain old balloon angioplasty has been the treatment of sorts in the past, and it leads to dissections, possibly emboli. A lot of times you may need bailout stents. There's inability to cross these lesions. There's poor expansion. And then most recently, recoil has come in the picture. When we look at calcium, if you look at the populations of people with peripheral arterial disease in this first graph, people who have claudication and then critical limb ischemia, those people who have critical limb ischemia have more tibial arterial calcium. And then if you look to the right of the screen in terms of this graph, the degree of calcification is a predictor of amputation and wound healing rates. It is deleterious. When we look at medial calcium below the knee, there's more prevalence of medial calcium below the knee than above the knee, as you can see here in the anterior tibial and posterior tibial distributions. The medial calcification leads to this arterial stiffness, lack of expansion, and acute failure, restenosis, and ultimately complications such as spiral dissections, recoil, emboli, etc. Remember that we discussed recoil earlier, at least I brought it up. Recently, Bowman and Baumgartner published a paper looking at tibial arterial treatment and recoil. Using balloon angioplasty in this population of people, angiographically, after treating the lesion with balloon angioplasty, the initial angiogram looked pretty good, as you can see in the middle here, after balloon treatment. However, if you waited 15 minutes, you had a significant amount of recoil. In fact, on average in the population, there was on average there was about a 29% recoil rate post balloon angioplasty at 15 minutes. This again leads to this medial calcium causing arterial stiffness, leading to vessel recoil, and ultimately restenosis. When we look at the current technologies to treat calcified lesions, none of them are perfect. Remember, balloon angioplasty, as I just described, can lead to significant complications such as dissection, perforation, and then ultimately recoil, as we saw in this last picture. Drug-coated balloons to date have not shown significant benefit. And maybe one of the reasons is that the calcium prevents the biologic uptake from the balloons. From bare metal stents have not shown any improved efficacy over balloon angioplasty. The only one in short lesions has been drug-eluting stents that have shown benefits. However, stents prevent future treatment options, and if we could have a leave nothing behind strategy, we would probably prefer it. In terms of atherectomy, again, it's very good at modifying plaque. not completely understood how it affects medial calcium. So this recall issue may be an issue with certain atherectomies. And again, globally, it's not the standard. In terms of cardiovascular calcium, again, these are OCT images showing both intimal and medial fracture. And then this micro CT demonstrates calcium fractures leading to an acute reduction in mean gradient and improved coaptation of the aortic valve leaflet if used in aortic valves. This, again, is the showing that IVL addresses both intimal and medial calcium. Andrew Holden presented at Link in 2018 a sub-study looking at OCT, and what he showed by OCT is that in the periphery, the intravascular lithotripsy did crack both intimal and medial calcium. When we look at the disrupt below the knee study, this is an interesting study I'd like to touch on. It has our typical comorbidities for this peripheral arterial disease population. They're older, diabetic, hypertensive, hyperlipidemic. The one thing that's very interesting, again, these are all below the knee, but there is 100% moderate to severe calcium, which, remember that in most studies, these people are excluded. In terms of the endpoints, the primary safety endpoint of major adverse events at 30 days was 0%. The primary effective endpoint, the acute reduction in percent restenosis, was met, as well as the secondary endpoint, post-IVL residual stenosis of less than 50%, was in all of the people. In terms of it being safe, as you can see to the right, only one patient had a dissection, and perforation, distal embolization, thrombus, no reflow, and abrupt closure was null. When we look at the device, just to re-mention this S4 device, it has 4 emitters, 40 millimeters in length, 5 French compatible, and can treat from a vessel diameter from 2.5 to 4. And in the below the knee study, it treated the pop all the way to the foot. This is a case that I did displaying recall, just like Bowman and Baumgartner did. This was a 50-year-old gentleman, typical comorbidities. Ulcers in the right lower extremity, had a previous left BKA. You can see the ulcers. All the tibials were occluded. So I went after the anterior tibial, had to come from a retrograde fashion, used a double balloon technique, finger of God, was ultimately able to open up the anterior tibial, as you can see to the far right, with balloon angioplasty. I waited 15 minutes after the intervention, and in fact waited out to 30 minutes to see what type of recall we would get just with plain old balloon angioplasty. And what I did is I tried to depict it here. So I used a ruler, the reference point, so I could be accurate at where I was measuring across the board. And as you can see, out to 30 minutes, over here in the red column, recalls went from about 6% all the way up to 40% at different points along the lesion, out to 30 minutes. So again, very impressive. Sometimes we may be fooled that we've got an excellent result, and then 15 to 30 minutes thereafter, you have a significant amount of recall. This is one last case. This is a 78-year-old gentleman, typical comorbidities, presenting with a medial plantar wound, which was not healing. I think everybody can appreciate looking at below the knee. There's a significant TP trunk stenosis, posterior tibial stenosis, as well as proximal perineal. What I was able to do here is I wired the posterior tibial, and with a 4x40 intravascular lithotripsy device, was able to treat the posterior tibial and the TP trunk lesion. The second shows me pulling it back across the TP trunk, again delivering IVL therapy. And then without removing the IVL balloon, I then rewired the perineal and then just advanced the intravascular lithotripsy device to treat the perineal without removing the balloon. So again, this is pre to the left, and then this is post to the right. And I think what you can appreciate is there's no significant dissections. We get a very nice result with opening the vessel, and ultimately with this improved flow, we were able to heal the wounds in the medial plantar region. The other thing too is this was cost effective because the amount of time that we were in the lab, since I was able to just pull the balloon back and rewire it, it was very effective in terms of time saving within the lab. So in summary, critical limb ischemia is a growing problem in patients with peripheral arterial disease. Calcification, again, the Achilles heel for a host of reasons. Number one, from technical success as well as to complications. There's limited data with severely calcified lesions, as I alluded to earlier. Plain old balloon angioplasty has a poor safety profile as well as technical success. Drug-eluting therapies have not shown benefit to date. And atherectomy may have promise, but there's questions of whether it actually affects medial calcium and maybe this recall. IVL has been shown to treat both intimal and medial calcium, and the infrapopliteal results have been safe and efficacious. Additionally, the 30-day results of the infrapopliteal safety results showed no major adverse events, including target lesion revascularization or amputation in the Disrupt TK's trial. Thank you very much for listening to me. I'm going to kick it back to you, Mariano and Marco.
Thank you, George.
Thank you very much,
Thank you so
George.
much for your time and for your fantastic presentation. In the meantime, we received some questions from the audience. I have a couple of questions for you, but I'm pretty sure that also Marco will have someone for you. We have been doing with Marco together experience with shockwave in Albano, and I had the opportunity also to use shockwave balloon in another moment, in another situation, out of my cath lab and also in my new cath lab here. But our experience, my personal experience, is not so big like yours. So I never had a complication, never. That's the reason why I want to ask you, which is the type of complications we could have with shockwave. If you have had some complications, what you can tell us about complications related to shockwave?
Great. So anecdotally, in with all of the cases that I've done, dissection would be it's rare. But if I was going to have a complication, it would be a dissection, and you may have to place a stent. Typically, it's in that coral calcium, those hard round plaques. I've not had any perforations, I've not had any emboli, and no spiral dissections. So the dissection located at the place that I've treated would be the thing that would happen if it's going to happen. But the majority of cases, it's very rare.
So you never have a distal embolization?
I have not. None that are clinically significant. And Mariano, it's a great point. After every intervention, I always take shots all the way to the foot to make sure there's no obvious large vessel emboli that have occurred. Because as you know, it can happen with any device. Just because I haven't had one doesn't mean it can't happen. So I would imagine just make sure that you continue to take those shots to the foot, because I would imagine on some occasion you may have one.
The reason why I ask that is because I never had a distal embolization with shockwave, but every one of us know pretty well that if you have a distal embolization in this type of calcified artery, it's very challenging to manage it. It's very challenging to treat it. So we can, in some ways, say that it's a very safe strategy.
I agree wholeheartedly.
Marco, do you have had any complication with shockwave?
Not yet. not yet. Not yet. No, I have a question for George, and I think could be useful for everybody. The main problem, I think, when we are treating so calcified lesion below the knee is the profile of the balloon. It's very difficult sometimes to cross the lesion despite the shortness, despite lesions are very short. Sometimes it's very difficult to cross the lesion with device, especially with this kind of device. And for technological problem, the profile is not so low. So sometimes we need to pre-dilate if we succeeded in crossing with another balloon. What do you think about pre-dilatation in terms of sizing? If we want to be effective with the device, with the shockwave balloon, how much can we pre-dilate, and if we need to pre-dilate or if we have to?
Yeah, I think that's a great question, Marco. And I think that ultimately the goal of pre-dilatation is just to deliver the IVL. So you want to take a low profile balloon. You don't want to use the balloon to rupture the vessel, to completely fracture, because we're trying to prevent those spiral dissections. So what I usually do is I pre-dilate with a 2.0 balloon, and I may take it up to max pressure, which is 2.3 millimeters, just large enough so I can pass the IVL and then to slowly inflate the IVL so we can effectively treat it. But we commonly have to use pre-dilatation with another balloon. That's not uncommon. But I think as long as you stay low profile, you don't run the risk of complications that you typically run in with balloon angioplasty.
Okay. Very nice. In the meantime, Marco, if you agree, we have 4 questions from the audience. Let's go for the first. Do you always need OCT images to assess the efficacy of the AVL?
No, you can use intravascular ultrasound and just plain angiography. I think what a 3-dimensional device gives you, such as IVUS or OCT, is exactly what's going on inside the vessel. So it's nice to not have to guess the size of the vessel or the type of plaque. And if there's a complication or you don't understand exactly what's going on, a 3-dimensional imaging is very helpful.
Fully agree with you. You don't need it. It is very helpful, but in most of the cases with the 2-dimensional angiography, you can understand and check the result. The next question, what is your suggestion for heavy calcified distal tibial lesions which don't allow any balloon or catheter cross even after crossing with or 14 guide wire? Well,
so I would so this is where atherectomy comes into play. Okay, so let's say we've exhausted our peripheral realm. We've exhausted the ability to take a coronary balloon, which is your lowest profile balloon, and it's unsuccessful. So then what I would do is this is where I would use atherectomy in something with a frontal sanding. So I would take an 014 wire by it and then use atherectomy to make a pilot channel and then deliver your therapy.
Yeah, personally, and I think Marco will agree with this idea, multiple of these cases in which you are able to cross with the guide wire, but no one catheter or balloon cross. What we do is to externalize the guide wire. We have been discussing multiple times about that, and using a rigid metallic catheter that allow you to dotterize the artery, pass this catheter, remove it, and finally, or AVL or atherectomy or something else. But yeah, these cases are challenging for themselves. The next question, in the subintimal plane, use AVL, give some effect?
Yeah, I think it does, Mariano. And I think the reason why is where you are in the vessel, you're still delivering therapy. So I think it's very helpful to prep that calcified lesion, whether you're in a subintimal space or whether you're in true lumen. And to be honest with you, we probably all go subintimal. Unless you check it with some sort of 3-dimensional imaging, we may be subintimal and just not realize it, going in and out of the plane.
Yeah, I agree with you for the use in the subintimal space. Probably it has an effect.
May I? I have a question. George, we normally spend a lot of time to try to maintain the true lumen crossing, especially when we think to deliver a particular treatment like intravascular lithotripsy and atherectomy, for example. But is it really mandatory to stay in the true lumen, or your message, as I understood, is, well, the important is to cross the lesion wherever we are. Then we can deliver with safety intravascular lithotripsy.
Yes, yes, sir. I believe that is true. That one caveat with that is that that's true with IVL. With atherectomy, I believe that's true with laser. If you go subintimal, you have to be careful with some of these atherectomy devices, because the atherectomy device will wrap up that plane and you can get the atherectomy stuck and it causes a big problem. So if I was going to say safely that laser atherectomy and IVL would be my treatments of choice in the subintimal plane.
Okay.
Good.
Thank you very much. This is a very important message, because it changes a little bit the perspective of this treatment. I could think we have a larger spectrum of chances to use this treatment. So intraluminal and subintimal, and this is great. Thank you very much.
Yeah, and I think it is going to add something more, because when we cross subintimally, the problem we could have is recoiling for sure. And it is related to the plaques that are out of the new lumen, remain out of the new lumen. So if AVL is effective, helping us to crack this plaque out of the lumen, well, in many cases we could sometimes or maybe avoid stenting or just improve the primary patency of this new subintimal lumen related to do not have recoiling. We have another couple of questions. Yeah, sorry.
Sorry, just a minute. To be provocative as usual, what about the use of this technology preparing an SFA or popliteal artery for superstent?
Absolutely. I think this is a great, it's just as using any other modality such as effective balloon angioplasty or atherectomy, you should prep the vessel before any stent, but especially Supera.
In fact, this was the discussion of the case in the morning, and this was what I was thinking about, to use AVL in the subintimal, in this very calcified, heavy calcified SFA that we cross subintimally, and what you obtain is a spiral subintimal space. You can crack the plaques, open the vessel properly, and finally deploy the Supera. That's probably one interesting chance for the future. Okay, if you agree, the last two questions, and finally we will leave George go to finish the work. If you have a distal embolization, how do you manage it? I think this can be related or not to the use of AVL, and well, how do you manage it, George?
Sure. So I would, of course, go and retrieve the plaque. The question is, how do you retrieve it? I think there's some good thrombectomy catheters currently on the market. One is a Spire, which is a handle that you can use, you can attach to any catheter. Another is the Penumbra, which has great suction device to pull out plaque. But let me tell you about a new one. It's called the Wolf catheter. And this catheter is a weave on the outside of the catheter, and the weave actually is pulled inside the catheter as you advance the catheter forward. So it grabs the emboli or thrombus, whatever it may be, and it's very effective. It's a startup, but it'll be coming to the market soon.
Okay.
Good.
Thank you. Thank you very much.
Well, the last question again about the use of embolic protection devices with shockwave or atherectomy. Your thoughts?
Yeah. So if the plaque is soft, okay, in any region, or if it's a long chronic total occlusion, I weigh on the side of placing an embolic protection device just for the fear of throwing something distally and affecting my outflow. With the shockwave, shockwave, I'm less likely to use embolic protection because I've had great results. With atherectomy, I'm more likely to put down embolic protection.
Okay.
Perfect. Very clear. Okay,
Great.
let's
Thank
continue.
you very much.
George,
Marco,
for
I want
you.
to, yeah, thanks to both of you, and I want to congratulate you on another wonderful year of Click. I can't wait to see y'all next year. Okay, I appreciate
sure.
it.
Thank you,
Thank you.
George. Thank you so much for your time. Big hug
Thank
for
you,
you,
George.
and see you.
All right, see you later.
See you. Okay, Marco, I think now is your time.
Yes. Okay. So thank you very much. I will show a recorded case, quite complex, but I hope could be, first of all, didactical. So the title is Anterior Tibial Occlusion and Bifurcation. Could shockwave treatment make the difference? This is my disclosure. And this is the case. The clinical situation is 83 years old lady with a huge collection of pathologies. So diabetic with an ischemic cardiopathy, neurovasculopathy, hypertension, dyslipidemia, with an history of bypass graft, coronary bypass graft of the Lima on the anterior descendant, a previous left transmetatarsal amputation, as you could appreciate and you could see in the picture, and the previous right carotid endoatherectomy. And actually, the patient has a renal function, impaired renal function with serum creatinine of 1.9, and was accepted in the lab with the first and fourth dose gangrene and a very low TCPO2. So we decided to study the patient. You can see here the attempt to have a quite acceptable angiography with CO2. The patient was a little bit difficult to achieve a cooperation, and that's why you can see the picture are a little bit with an effect of movement. Anyway, diffuse calcification in the FEMPOP axis. I thought to have a quite tight stenosis in P3. You can see better with the contrast medium. So the picture, the movie number 3, and a complete occlusion of anterior tibial, posterior tibial, and only peroneal artery, very, very tiny, with a distal rehabilitation of the foot. We have the movie of the foot through collaterals of peroneal. We have a common plantar artery and a medial plantar artery, and in the anterior circulation, we can see a distal anterior tibial with the pedal artery and the arch. So we decided to approach the patient in the common way. So antegrade approach under ultrasound guidance, the puncture, and deploy a 6 French sheet. Now I can share with you the movie. Let charge. Okay, just some seconds to load the movie. You have to think the original time of this procedure was 2 hours and 35 minutes, and I had to condense in 10 minutes. So this is the intraluminal progression of my first wire, which is a Terumo Advantage 1.4, and I try to remain in the true lumen in the middle of the calcium, just rotating the wire with the support of a 4 French Berenstein catheter. You can see how difficult it is to go forward, how difficult it is to maintain the position in the true lumen. For sure, the 4 French catheter is too big to support our wire, and it's very, very difficult. So the progression of the wire seems to be better with the support of a CXI 1.4 support catheter. And you can see we arrived more or less at the middle third of the anterior tibial, and after a lot of attempts to cross the occlusion, always with the drilling technique, I wanted to avoid completely to create a loop. It was really, really difficult to advance the wire in the lumen. So that's why I decided to approach the patient with a retrograde puncture at the distal pedal artery. Distal anterior passage with pedal artery. You can see the position of the amplifier in the oblique craniocaudal projection, the local anesthesia with the roadmap, and finally the puncture of the calcified vessel under fluoroscopy with a 21 gauge Cook needle dedicated, the insertion of the 1/8 wire. It's a control wire from Boston, V18 from below, and again the rotation of the wire in the middle of the calcium from below. You can see the movement, the rotation of the wire, and exactly in this moment, it was the feeling was, oh, well, I should be in the same lumen, but you can see it was really an impression. I was in the true lumen from below, I was in the true lumen from above, but this time it was not easy to communicate because the occlusion was still there. So a lot of attempts from below, from above, from below, from above. You know, it's a job. It's a job of passion, of patience, and we changed a little bit of wire. So from the V18 control wire, we shift to a Stato 30 from Asahi to be a little bit more aggressive. You will see the new wire arriving from below after some attempts. You know that we use still the step-by-step technique, so we never choose aggressive wire as first choice, but we follow the philosophy of the wire escalation. So after this hydrophilic advantage 1.4 wire and 1/8 wire, we decided to shift to the Astato 30. That's the Astato 30, and you can see that the attempt was a failure, because to cross this lesion was really, really, really tough. So the support of the 1,4 CXI was so good from below that we could pass a 1,4 directly in the other 1,8 CXI. So when we succeeded finally in crossing the lesion, we externalized the wire from the groin, and we could start to divide the vessel. You can see the 4 French Bernstein catheter arriving in the tibioperoneal trunk, and we are ready to cross with a second wire in order to prepare the 2 vessels to be pre-dilated. This is a 2 millimeter jade high pressure non-compliant balloon to achieve a pre-dilatation of the anterior tibial artery. And you can see we push the catheter up to the entrance, and this is the acute lumen gain. After this, we could finally cross with the IVUS catheter. This is a 1,4 IVUS, and we try to understand the real size of the vessel and the real consistency of the wall. You can see the white hyperreflective wall, which is not really completely a sign of calcium, because in some point probably it's a fibrocalcific. Only in some aspect we have a shadow, a black shadow, so we have really calcium inside. But the radiological aspect is to have a great calcium. And you can see here the measurement of the vessel. And I was a little bit surprised, because the vessel at the ostium and in the proximal part was 3.5 millimeters. So larger than I could imagine. You can see here the distal P3 lesion, so severe lesion in P3 with a lot of material inside, so plaque, endoplaque. And this is finally the shockwave S4 3.5 by 40. We used 8 cycles of 20 pulses in this area to achieve this kind of result. And then we passed the same size of balloon in the peroneal trunk and proximal peroneal artery to crack the calcium. So we decided, after this check, to use a new balloon, a sirolimus coated balloon. The name is Magic Touch, and so we will try to understand if sirolimus is better than paclitaxel to achieve a good patency. You can see the treatment of P3 with another S4 millimeter by 40, and we complete the procedure with the recanalization of the peroneal artery as far as was possible to arrive with our catheter. Again, a didactical point, you can see a second wire passed in the anterior tibial artery distally. We want to achieve a balloon assisted hemostasis. You can see a second 1,4 wire arriving in the distal AT in the middle of the calcium, supported by directly by a balloon. The wire is another advantage, 1,4 by Terumo. We could successfully cross the area of the puncture, and you can see how difficult it is to cross with the balloon. We pull a lot the balloon to trying to predilate the area, and again it was really difficult. So we are now predilating with a 2.5 non-compliant ultra high pressure balloon Jade from Orbus Night, and finally we could cross, you can see here, with a short 2.5 by 40 old balloon. Is my God, in this moment I can't remember the name. It's my favorite. It's Amphirion. Sorry, my mind is full. Okay, with the Amphirion balloon 2.5 by 40, we finally achieved the hemostasis. We were able to cross the lesion. Here is the balloon, and we inflated the balloon for 3 minutes at the pressure of 8 atmospheres, and you could see the acute results. We finished again in the peroneal artery for the residual stenosis in the distality, again with the 2.5 balloon. We finished the last touches, the last details in the peroneal, and then we checked the acute results. So this is the complete recanalization of the tibial arteries, and after this, again IVUS, and you can see the lumen gain. It's in my experience not so big, but it's a good result, because we have a nice lumen around the probe, and no dissection, no thrombus in the anterior tibial artery, especially in the proximal part where we use the 3.5 balloon, and again in the distal P3 where we use the 4 millimeter balloon. So after the IVUS check, this was the anterior anteroposterior view of the foot. So the final view of the anteroposterior of the foot, and I can show you now that the movie has finished. I can show you now the final result in tibial vessel and foot with a nice outflow towards the forefoot. The patient underwent to another transmetatarsal amputation. So we are waiting. The patient has been treated 2 weeks ago. So we have to wait a little bit for the first follow-up. But this was the acute result. You can see here the perfusion angio. In the left, you have the comparison of the two curves. The first curve is the purple one before the procedure, and the white one is after the procedure. So we if we compare the density of the contrast medium in the forefoot and the time of arrival of a contrast medium in the forefoot, you can see how good was the acute result. So in conclusion, calcium matters and impairs acute and short midterm result, especially in below the knee artery. For sure impairs the drug absorption in the vessel wall, and so we have to try to crack the calcium if we want to use the drugs to help our patency, and shockwave can crack plaques, allowing remodeling and drug absorption in the vessel wall. Of course, one limitation is the length of the balloons. We have actually quite short balloons, and so we have to use a lot of balloons if we want to treat all the artery, and that's why we focus in this case, but in our experience, the use of this technology for the bifurcation and for the proximal tract, which normally are quite complex to treat, and recoiling is quite immediate. So thank you very much for your attention, and I'm ready for your questions.
Well, thank you, Marco. Amazing case, like always. Let me say welcome to Andrea Casini, that he just arrives. Thank you, Andrea, to be here with us, and welcome.
Thank you to you, Mariano. Thank you, Marco.
Big pleasure.
Hi, Andrea.
Marco, impressive case, for sure, very complex and very challenging, related to the amount of calcium and related to the not only the anatomy, but what was occluded and what was patent. A couple of questions for you, but just to try to grow for myself. How far do you believe we can go with S4 EVL balloons? Because you limit. You did a big job, and finally use shockwave in P3 and in the ostiums. I think this is going to be one of the best options to reconstruct bifurcations when we want to avoid stents. But do you believe changing the balloon, because probably 3.5 was so big, do you believe it will be possible to go down in anterior tibia and reach the foot with this balloon, considering the profile?
After a pre-dilatation, maybe. To be honest, I don't know. I don't have this experience. I think that after a pre-dilatation, an aggressive pre-dilatation, aggressive, I mean, we used a non-compliant high-pressure balloon, and sometimes it's difficult to cross the lesion with low-profile balloon too. So, as you could see, to close the puncture site and to cross with the balloon, it was terrible. So probably with this balloon after the pre-dilatation could be possible, but I'm not sure.
The question was related that you have been working in a telespheric fashion. So I was thinking that probably when you have the antegrade retrograde, it could help after pre-dilatation to go down,
yes,
with a 2.5 or 3. I saw perfectly the difficulties to cross in front of the retrograde axis, but finally, if you are able to go down with the AVL, you will have the chance to crack all the plaques all the way of anterior tibia. I think following this, it could be a very nice strategy, and the balloon will pass.
Yes, I don't know if with this technique, so push and pull the balloon, we have to manage a technological object. So I don't know the possible and potential damages on the balloon with this technique, push and pull. So, but maybe it's possible, maybe could be useful. and we will try. We will try, and we will verify the possibility.
Yeah, for sure, for sure. It was a stimulating question for you, because I believe in the future we will have more chance to use in better way this type of balloons following the new technology, the S4 technology. Okay, I see that there is no questions from the audience. So you have been talking also about Magic Touch, the new sirolimus eluting balloon. I had the chance to use it a couple of times also. Do you have any short-term, mid-term follow-up about that to tell us something?
No, I'm sorry. I used for the first time 2 weeks ago, and that's why I told you I'm waiting for the first follow-up after 30 days, the ultrasound follow-up for the patient. For sure, the peripheral use of sirolimus application applicated on the balloon could be and could make a difference in this period. We know everybody of us knows very well the effects of the Katsanos meta-analysis on the opinion of the effectiveness and safety of the paclitaxel balloon. We know the warning of FDA, and okay, in Italy we do not have still limitation, not yet, but we are obliged to tell the patient, well, for you there is the possibility to use a particular technologies with the particular drugs, but there is a paper describing the potential death increase after 5 years. So in the long term, this is the only mandatory rule to tell the patient and to use paclitaxel device now. Sirolimus seems to be, because sirolimus is cytostatic and not cytotoxic drug, sirolimus seems to be safer and maybe in the coronary artery had a better result compared to paclitaxel. So again, we try to shift coronary and cardiac technology into the peripheral vessel, and we hope this time could be really effective because sometimes we applied coronary technologies thinking that because it works in the heart must work in the limb, and it's not true. So we have to wait for results, and we have to have more data about sirolimus in peripheral.
Okay, very clear. I have a question for you, Andrea. Thank you to join us. And even if you arrived late, the case from Marco was one of these cases that we could describe like no option patients. So fully calcified arterial disease, and also in the distal arteries. The result was incredible because there were many small arteries. So I don't know if we can catalog this patient like a SAD patient, like a small artery disease patient, but after DVA strategies, do you believe that we must today continue trying to treat these patients, and if we fail, shift for DVA, or is better to go directly to DVA? Open your microphone, Andrea, please.
I think now you can hear me. Okay, I think it's the better way, in my opinion, in this kind of patient is to try to do angioplasty first, and then straightly follow the patient in outpatient clinic. And if the results are not so beautiful and the outcome is not so good, we can think to arterialization of the foot. but the endo approach first, it's the best way, in my opinion. The only thing that I can see as an arterialization first strategy, when you have the complete patency of all the vessel above the ankle, and you have a poor set disease. So in this kind of patient, I think it's better to think to arterialization first than endovascular approach. But in this case, when you have, and I don't see the basal angio, but I think in this patient there was a mix of bad and sad, big artery disease and small artery disease. So if you improve the run-in, if you resolve the bad transmission, the big artery disease, and you can improve the tissue blush in the foot. And so in this kind of patient, I think endo first is the best strategy.
Thank you. Very, very clear.
Thank you very much.
We have a couple of questions from the audience. The first one, in popliteal stenosis or occlusion, when to choose shockwave and when to choose superstent, based on what? Personally, I believe that is different between to treat stenosis and occlusion, and for sure depends on the crossing also. If you have stenosis, usually if you have a calcified stenosis, the crossing is so fast, so good, usually you can use shockwave without any problem, and maybe it will allow us to avoid stent more than probably, quite sure. It could be a strategy to leave nothing behind. If you have an occlusion, it is quite different because the crossing could be not all in the lumen, there could be some passages in the subintimal way. And again, it could be a good option after the discussion with George to use shockwave and to try to avoid stenting. But if you finally do not obtain a good result, the stent as a bailout could be the correct option. What do you think, Marco?
Yes, for sure, for sure. In occlusion, probably the main issue is is to scaffold. So in a popliteal occlusion, we could have a nice acute result, but probably we need to help this result to stand for mid or long time. So could be mandatory, maybe not immediately, not the first time, but could be a concrete and a good sense rationale to scaffold with the super stent. Stenotic lesions are different, so the option to treat them with angioplasty and with the help of intravascular lithotripsy could be a nice option, especially if we can help the lesion with the drug-coated balloon association, with a drug-coated balloon association after cracking successfully the lesion. So
perfect.
I agree.
Very clear. Very clear. And for sure, even in an occlusion, EVL could be of help to prepare the lesion before stenting.
Yes. It's a good option, and I learned from George this option. So okay.
Okay, if you both agree, let's continue. This is my time for my case presentation. Let me share in that way. Okay. Can you hear me? Can you see my presentation? Sorry.
Yeah.
Okay, perfect. So the title is Fighting Against Calcium in BTK Segment, the Intravascular Lithotripsy Strategy. This is a case, sorry, I went too fast. This is a case of a lady with a 71 years old, no diabetes. So she arrived for a long-term rest pain, and she was not diabetic, no other risk factor. She only has arthritis rheumatoid, and she did more than 20 years use of cortisone. So you can imagine the type of the vessels that we are going to find. She was enrolled for 4 class. The TCPO2 was low, was 21, not the lowest, but was low. And she did a previous endovascular therapy, a treatment, and stenting in the SFA. Let me show you the images. You can see the SFA and you can recognize the stent. The stent deployed was small for this SFA, but the vessel was still patent with good inflow, some plaques close to the tip of the sheath, but nothing very important. I was able to measure the delta of the pressure and it was not significant. So fem-pop axis patent, and as always with these patients, a focal disease below the knee and below the ankle. One case, very challenged, one of the challengest case I saw here in Cotignola, with occlusion of anterior and occlusion of posterior, and very bad plaques in the TP trunk, and very diseased small peroneal artery. So I start with the 6 French sheath in the common femoral. Look, the distality, the anterior tibial is kink before the ankle. So this is one of the cases that for sure I consider in a case with ulcers, I consider for DVI, because it's quite impossible to cross this lesion. So O14 guide wire, 4 French catheter. Look, the guide wire engaged, or I engaged with this guide wire. It was a Victory guide wire. I engaged the 80, and the 4 French catheter was unable to pass. So I deployed the 6 French short sheath in the common femoral, and finally used a 4 French long sheath through this 4 French, through this 6 French, sorry, to try to improve the support of the sheath. The 4 French sheath was unable to engage the anterior tibial, so I pre-dilate at 3 millimeters. This is a 3 millimeters short balloon that allowed me to pre-dilate the ostium of 80, and finally to engage the 80 and go down. So I pre-dilate all the anterior tibial artery till the ankle level, in which there was this kink, this curve that I was finally unable to cross. But before it, I was trying. So push again the 4 French that was able to engage the anterior tibial, and even after 3 millimeters pre-dilatation, the 4 French sheath, this is a biotronic sheath, was unable to engage it. So I said, okay, let me use this 4 French, and with a new balloon and a new guide wire, I tried to cross in the lumen, tried to go subintimally in this anterior tibial, and finally what I obtained was a perforation. So I avoid the retrograde access here because I thought the same difficulties from antegrade like for retrograde. The vessel is curved and there was no any option to straighten this vessel. So I was more sure it was a failure. But before to leave everything there, as I said, I shift many times the guide wires, always in O14 platform, till the point I realized I was out. I was in a perforation. So what I did was to remove the guide wire, check, so the contrast between subintimal and out, and decide to shift and to change. At that time, I leave the anterior tibial, engage the TP trunk, and try to cross the posterior tibial. Posterior tibial was not so different because the proximal part was quite easy. But when I arrived close to the ankle level, again, the same difficulties. Not the same type of curves, but curves. CTO guide wire, this is a Victory O14 25 grams, unable to engage the proximal cap of this occlusion. And look, the diameter of these vessels are very, very thin, very, very small arteries. So calcified and very small. So finally, what I said to myself was, okay, the patient has a rest pain. Let's try to improve the perineal and the TP trunk. Well, the forefront catheter, the forefront sheath, was unable to cross the TP trunk. So what I did was, okay, let's fix it with the shockwave. I used the S4 3.540. There was no specific pre-dilatation there, and the catheter was able to cross, as you can see. It engaged also the ostium of perineal, and I did all the cycles available in this catheter between the TP trunk and the ostium of the perineal. You will see multiple cycles there. I deflate, repeat it between the TP trunk and the P3 segment in the popliteal artery, and so on, trying to, in some way, crack the plaques as much as possible. In some segment and in the final cycles, I increase a little bit the pressure. Rather than to use the balloon at 4, I arrive to 5, or in some case to 6, trying to have more power, trying to crack the plaques more in deep. And after a couple of cycles, I check, amazing result, but there's still some plaque that can be improved in the proximal TP trunk and in the distal P3 again. So again, I pass with the balloon, the same used balloon. So the technology, as you said, Marco, we need to respect this technology, but this technology is, I think, very nice and very appropriate for this type of cases, because even the used balloon was able to pass again. And finally, I obtained something that was acceptable from my perspective. So move forward with a Magic Touch sirolimus eluting balloon, 4 millimeter, 12, 120 millimeters. I inflate the balloon at nominal pressure, still some small plaque in the ostium of the perineal, but I decide to check and to finish there, obtaining this direct blood flow in the pop, in the TP trunk, and in the perineal artery that for sure allow me to avoid stenting in this type of case, to improve the inflow and the perfusion for the foot, and to have a better result in the foot arteries. I am going to show you the final answer in the foot that for sure improve through the perineal, through the posterior branch of the perineal, and through these multiple collaterals. Now I was able to see 2 branches of the median plantar artery and 1 big tarsal artery, lateral tarsal artery, and all the metatarsal branches. So many collaterals, for sure, an improvement in the perfusion. After 1 month, the lady after 2 weeks, the lady was in the outpatient clinic, and she showed me, she manifested me a complete resolution of the rest pain. So thank you so much for your attention.
Thank you, Mariano, for the nice case. Very, very difficult, very extreme case. Unfortunately, beyond the anatomy, probably there was the curve in the ankle, especially in the anterior. They were due to the surgical approach to the ankle received by the patient. I don't know, but sometimes creates really impossible obstacles like this. And then the consistency of that calcium, so black, so dark, is particular tough, particular hostile to any puncture, any treatment. So I think you achieved a very, very nice acute result. Andrea, do you think a case like this could be a good sense to think immediate to an arterialization, or we have to try to do some endovascular attempts still?
No, because the patient hasn't tissue loss. In my opinion, the arterialization has a stricter indication when you have rest pain and tissue loss. This patient has only rest pain, and so I think the procedure is the best procedure for her. In this patient, we didn't any kind of arterialization because you think that in 30% of the patient without tissue loss after the arterialization, you can do in this kind of patient a sort of TMA amputation because there is a sort of phlegmasia in the post-op. So the indication in our center, in our series, are only patients with lesion, tissue loss, and rest pain.
Okay.
Yeah,
So
very clear.
that's a nice information. So the presence of tissue loss is an indication for DVA in your center, and not only rest pain.
No.
Okay.
At the beginning
Perfect.
of our experience, we do arterialization also in patients with rest pain. But after 2 or 3 patients which we need to carry on a foot amputation, we change our indication.
Okay. Mariano, there is a question from the audience.
Yeah, please.
Why you don't delay the stenosis of the big collateral?
Of the big collateral, what means the stenosis of the big collateral?
I don't
So
know.
probably who answered this question was talking about some of the perforant branches of peroneal. Well, I had many difficulties to go down with the peroneal related to the guide wire crossing and the balloon crossing. And honestly speaking, again, trying to follow the clinical indication, when I saw the result, I said, okay, I improved pretty much the perfusion for this food because I was able to show many other vessels compared to the beginning. So I decided to stop there, and finally there was a TCP2 increment and the rest pain resolution. So I think it was correct at that moment, but honestly speaking, I decided to stop related to the rest pain, not tissue loss. So I was thinking, okay, I improved the inflow, for sure improve the perfusion for the food. Let's see how will be the evolution.
You don't have a perfusion angio?
Yeah, I have. Yeah, I have. But usually, since I used to do the CO2 angio from the beginning, I usually avoid, because I don't remember, to do the perfusion in the diagnostic phase. And finally, if I do the perfusion for the final control, I don't have any chance to compare both images because I don't have the baseline perfusion.
Okay.
But
because,
yeah, it is a good suggestion.
No, but you know, we still have the problem. Everybody of us has the same problem: is to have available a system to evaluate our job immediately without waiting the next weeks. So the clinical modification, and sometimes, especially in this case where you don't have so much space for working, because you cannot succeed in doing the anterior, you cannot succeed in doing the posterior, you cannot arrive below the ankle in the foot. You try to treat the inflow, and even the dilatation of the inflow is not so apparently is not so huge. It's difficult to decide when stopping and when to continue. So that's why I asked you, how do you decide to stop with a good sense?
Yeah, absolutely. Fully agree with you, Marco. In these patients with a limit, because there is no tissue loss, but there is a rest pain, so it's the first step of CLI, in which you don't have too much space to maneuver in the recanalization strategy. It's good to have something. Unfortunately, I didn't perform the perfusion, but for sure it's a very nice comment to consider in the future. Absolutely. And I have this technology, so I was stupid because I have the possibility to do that. No, I mean, I clearly
stupid is who stupid does. No, absolutely.
I have the point.
It's a question
it's
about
a constructive observation.
Yeah.
Yeah.
There are no more questions by now, so I don't know if do you have another case?
Well, yeah, before to pass to the DVI, we have the other part of the calcium therapy strategies, and is let me share again. It's another case.
Wait a minute. Arrived a question about the use of intravascular lithotripsy in common femoral artery. What about this area?
I think I don't have any personal experience. I never try, but I think it's a very nice idea and could function perfectly like in any other vascular segment. In fact, here in my new facilities, the cardiologists use it frequently in iliac arteries pre-TAVI, before to cross with the big catheters, to create a space in the iliac arteries, avoiding or trying to avoid to damage the iliac arteries. So I think it could be also fantastic to be used in the common femoral artery in cases in which there is no indication for surgery.
Andrea, do you always prefer, as the guideline are telling us, to perform endoatherectomy in common femoral artery, or you sometimes decide to treat with something this area?
As a vascular surgeon, I prefer the surgery, but I think in our daily practice, we must treat the patient and not the angio. So in some cases, I think the endovascular approach is the better way when you have an old patient with comorbidities. So I think an endovascular approach can resolve the rest pain and perhaps the demarcation of the lesion. So I think we must tailor the procedure on the patient, much more than on the guidelines sometimes.
Fully agree with you. Yeah, sometimes the guidelines could be and can be a general guidance, but we must to tailor patient by patient the best strategy. We have another couple of questions, Marco.
Yeah.
If you agree, we can read it.
Yes, of course.
Cracking the calcium with AVL does not prevent it from reoccurring. So I'm not completely sure. Probably if you crack the calcium, it's not going to be a new calcium formation there. But are there any technology in the pipeline for dissolving the calcium or preventing recurrence? I don't know.
Me too.
Solving the calcium, I never hear anything about some technology that can dissolve the calcium or can avoid any calcium formation. So if someone have something to share with us, more than welcome to write for the answer. The other question is, in case of tissue loss, do you recommend it to give another trial for angioplasty I mean transcollateral or retrograde before proceeding to DVI. If following the specific case I show, I try anterior, I try posterior, and finally decide to go in the peroneal. If you lose the distal collateral, the distal perforant branch of the peroneal, you lose anything. So in this specific patient, I believe if you have a tissue loose and you obtain this kind of result, if it's not enough, you need to go forward for a DVI. There are no many other options.
I think we have to move on case because we only have 35 minutes left.
Okay, so this is the other case. I hope you can see my screen. Okay, you can see the presentation.
Yes.
Marco. Okay.
Yes.
Yes.
Okay. So the other option to treat calcified arteries below the knee, above the knee, is a STILF 360. It's a vessel compliance change through differential sending and pulsating force. We are going to talk about the orbital atherectomy. This is a case of a very young patient. This is 57 years old female with diabetes, hypertension, dyslipidemia, clearly chronic kidney disease. She was not under dialysis. Look, the creatinine 8.8. So Professor Dalla Paula said me, you cannot inject 1 cc of iodium because the creatinine was 8.81. Bilateral PhD, left CLI, Rutherford 6 class, the TCPO2 was 8, the Wi-Fi was 131, and she presented a ulcer in the fifth toe. This was the situation, not so bad. SFA and POP pattern anterior tibial, but with some anatomical variation in the foot because dorsalis pedis is incomplete, and it seems to have a plantar dominance, posterior tibial and plantar dominance for the forefoot. But plantar arteries were not so bad. So there was a long occlusion of the posterior, but 2 plantar arteries. So the bifurcation of the plantar arteries was diseased, was stenotic, but finally the distal and lateral plantar seems good. So I start with an antegrade access in the common femoral. I failed to cross. So I needed to use the retrograde access in the distal PT, posterior tibial. What I did was just to puncture the calcification. You can see the calcium there because there was no flow in the vessels. So I punctured the posterior tibial at the calf, at the ankle level, go up, and was able to connect both antegrade, retrograde, and do the telespheric situation. But it was impossible to cross even with the 1.5 extra small balloon. So no one balloon passed. The only balloon that engaged the proximal PT was broken during the passages. So I decided to do the atherectomy, having the telespheric. I open a 1.25 solid crown still, and I start, as always, in a telespheric situation. I was able, again, with both catheters, to change for the dedicated 014 Viper wire and to start with the atherectomy. The device functioned very well because it allowed me to go down and engage the proximal posterior, as well as to go down and up and down. You know, this device can function going down and going up in the anterogradely and retrogradely, or in the reverse way, and changing the speed between from 1.25 to, you can arrive to 2 and to 2.5, changing the speed of the passage of the device rotation. But the first passages, what I did was to use it only at the lower speed. Well, it allowed me to finally reach the distal the distal posterior tibial to pass a second guide wire, but here start the problems. Unfortunately, I was unable to register the video of this procedure, but when I reached the distal posterior tibial, this was the place in which I did the retrograde access. I was able to do 5 centimeters less, 3 centimeters in the lumen, and finally lose the lumen. So I did 4 centimeters subintimal and re-enter in the common plantar. When I re-enter with a Viper wire that is like a CTO guide wire. So it was open, so I said, okay, let me try this guide wire re-enter and allow me to go in the lateral plantar. So the fortune was to have the Viper wire in place, because otherwise it was impossible to change it. The problem was that, again, no any balloon arrived there. So the better balloon I had arrived here. And in front of this calcification, the balloon stopped. So I said, okay, I have the stilt already open. Let me try. But in the other hand, I said, okay, but I did a subintimal crossing. Okay, I will try to pass the stilt, the atherectomy device, without movement, no, in the rotation fashion. For sure, the atherectomy was not able to pass if it was not moving. So I finally crossed at the lowest speed and very fast the subintimal tract and engaged, as you can see, the plaque in the common femoral, in the common plantar, and was able to go a little bit more down to modulate this plaque. Well, after this, there was no perforation. I was able to pass with a 2.5 balloon, dilate everything from the plantar till the ostium of the posterior tibial, and this was the result with a CO2, with a direct blood flow in the anterior, no any problem or compromisation in the previous patent arteries, and direct blood flow in the posterior with good speed, the same speed than in the anterior tibial. And in the foot, this is a check that I did through the balloon after the first dilatation to check the runoff, because I said, okay, let me check if there are any distal vessel metatarsal branches, if there are any sign of embolization or something else. Everything was good from my side. I identified some residual distal stenosis between the lateral plantar and the arch, but I decided that the flow was acceptable, so I avoid to dilate this. And this was the final check through the groin, injecting the CO2. So I finished the procedure injecting 2 mL of iodinated contrast medium, and it was almost a contrast-free procedure. There was a clear improvement from the plantar side of the foot and a clear improvement for the fifth toe, that was the place of the ulcer location. So the final result after reconstruct the images, I think very nice images in posterior tibial, very, very nice images in plantar arteries, in which even if always have been working with the same speed related to the vessel diameter, the plantar arteries were smaller, they still did a better job. So looking yesterday when I was preparing the presentation, looking to the result, I today consider that could repeat the atherectomy in posterior tibial at a medium speed to improve a little bit more the diameter of this posterior. But finally, I was convinced the result was good, acceptable, and I did this 2 weeks ago, so I'm still waiting for the follow-up, the clinical follow-up of this patient. But Professor Dalla Paula told me that the bleeding during the foot surgery was more than acceptable. So again, thank you so much for your attention.
Wow, very, very nice case, very effective device.
Yeah, I think this device is very effective. I was quite lucky in this case, honestly speaking, because starting to pass the device in the posterior tibial, having the antegrade retrograde, allowed me to force a little bit and to, how can I say, help the device to engage the plaques. In fact, if you were able to see the last images, the tip of the catheter was a little bit torqued through itself because there were very complex plaques. Well, it took a bit of time. You know me, I don't have the time to dedicate not too much time. In this case, I was very quiet and polite and decided to invest more or less 30 minutes to do the atherectomy. So I worked 2 hours to successfully open this vessel and to very delicately arrive to the foot. And finally, I was so happy because the result was very, very nice.
How many passages?
Many passages, many, because every centimeter needed in that case to be passaged, and multiple times, going down, being back, stop, wash, start again, going down, going up. Finally, the balloon was able to cross, and so on. But taking account that when I did all the posterior tibial, to pass the second grade wire in front of the retrograde axis, I was able to push down the Beresheim, the 4 French catheter. So the lumen was good, but need time. You cannot go fast because you risk to damage the device or to damage the artery. In some cases, you need to increase the speed because sometimes you push and you can hear that the speed decrease. So maybe it's better to go to be back, to wait, stop, wash again, and start again. It takes time. When you need to do 35, 40 centimeters of collusion and calcium, it takes time. But in this specific case, it was very effective, very, very effective.
Yes, for sure. Well, I think we have 24 minutes. So I think if we supposed to be unable to do anything, we have a real no option, and I give the words to Andrea with their huge experience, because we are going to learn something. Thank you, Andrea.
Thank you.
No,
Thank
I'm sure.
Me too.
Can you see the?
No.
No,
No?
share your screen, please.
I share. Ok.
Sotto, bottone verde sotto al centro.
Sì, sì, è che non è il mio computer e quindi era tutto perché il mio computer si è crashato adesso. Vediamo. Riesci? No.
No, no yet.
Adesso?
Yeah, we have it.
Okay. Perfect.
Yes.
So,
Okay.
okay. My topic is the arterialization in no option patient. After 4 years of experience in arterialization, what we understand, what we learn. First of all, the patient. Which are the including criteria for this kind of patient? First of all, the patients must have an acceptable heart function, must have an acceptable life expectancy, and must give us the acceptation of the procedure. For what concerns the foot, all the patient must have a CLTI with a tissue lesion, tissue loss, rest pain. So all the patients are Wi-Fi ischemia grade 3. In all the patient, the infection of the soft tissues must be completely removed. And in all of these patients, we must have a disease of the foot arteries that we consider a no option by angioplasty or distal bypass. But who is a no option CLI patient? The definition of no option is not a static definition because it's changed according to the available technique and available skill in a certain place and in certain era. Nowadays, in our center, we consider an option patient a patient with rest pain, a tissue lesion, a patient that, according to Wi-Fi classification, has a high risk of amputation and has a high benefit from revascularization. A patient that at the basal angio show, as usual, the patency of the big artery and show, as usual, a severe disease of all the vessel below the ankle. A patient with the so-called SAD, small artery disease, a patient in which we can find any suitable artery as a target for an endovascular approach or extreme bypass. In this kind of patient, we develop our experience in arterialization. First of all, for well understand the step, we must introduce the concept of the fortress. Which is the fortress? The fortress is the foot vein system, as well described by Professor Lengua 50, 60 years ago. The foot vein system are divided in four systems: the superficial dorsal one, the deep dorsal one, the deep plantar system, and the superficial plantar system. The first step, we must build the way for the fortress. We must choose the inflow. The choose of the vein inflow is the first part of every arterialization. There are many different vein routes, but only two big highways in the leg. Consider that we count 3 arteries and much more than 14 veins. And when we choose the run-in, all the other vein systems become immediately outflow veins. The first choice, in my opinion, is the arterialization of the superficial dorsal system, great-saphenous vein, medium marginal vein. The second option is the arterialization of the deep plantar system through hybrid approach or limb flow technique. And consider that anterior tibial vein and deep pedal vein are the poorest of the vein system, and we rarely use this kind of system as an arterialization patient. The superficial dorsal system is the system that I prefer. The procedure is the faster and the safer. We do the arterialization of the great-saphenous vein and marginal vein, and this system has an important connection with the other vein system. In fact, we can reach the deep dorsal system, the deep plantar system, and we can see the posterior tibial vein, medium plantar vein, lateral plantar vein, deep plantar arch. We can reach the collateral perforators and the so-called forefoot cross, and we can reach also the superficial plantar system, that is the so-called Lejar sole. So now we built our route, and now we are at the fortress, at the door of the fortress. We must open the fortress doors. We must destroy the valve in the vein. How? We have some choice, some chance, as the ballooning, like in the first case, with the reverse valvulotomy, as Roberto is doing in a lymph flow procedure, or with a double wire technique, when we put a bare catheters in the superficial dorsal system with a 2 guide wire. We use the loop of the guide wire as a cutter of the valve. Now we destroy the vein, we enter in the fortress, we are inside the fortress, but our work is not finished because we create a fast circle of blood into the big vein, but we cannot serve any red blood cells going in the tissue. So we must escape from the fortress and get the tissue. How? We can have 2 hypotheses. The first is the mechanical hypothesis, in which the direct tissue nutrition is done by the reverse blood flow due to the valve incompetence. So the distal vein are recruited and due to the mechanical fatigue, and this is a distal recruitment of the vein due to the stump pressure that we create in the proximal side. This is not our hypothesis. This is an hypothesis of Alexis Carrel in 1906 during the arterialization of the leg of the dog. He see what is observed that with the pass of the hour there was a failure of the distal vein, and that's what happened in our patient. This is a patient with rest pain and gangrene of the second or third. This is the basal angio. This is the final result of arterialization procedure with a primary embolization of the stealing branch. And this is the time zero, 1 month at the 3 months. What we observe? We observe a recruitment with the pass of the time of the distal vein, with a tissue blushing of the foot that lead to the healing of the stump. This is a TMA amputation with dermal substitute, the skin graft, and after 3 months, our patient can walk with dedicated shoes or insole. And then we have a biological hypothesis. In some patients, what do we observe? We observe after the arterialization, the remodeling or the neoangiogenesis. The arterialization create a new foot distribution system. This is a patient that we treat 3 times with endovascular approach. Then we have a small artery disease and we cannot find any suitable target in the foot. We carry on an arterialization with a lymph flow procedure of the deep plantar system. We do the embolization of the stealing branch, and then we observe at the baseline, at the acute result, after 45 days and after 90 days, a remodeling, a neoangiogenesis. The vein system of the foot become the new distribution system. And in this patient, we carry on an TMA amputation with a tension-free surgery. And after 4 months, the patient is healed and walk. Then we understand that we must modify our approach because during the arterialization of the superficial dorsal system, we necessarily do an approach on the saphenous vein at the malleolus, but we have always some problems. So we create a new technique, what we call monassess technique, because how I told you before, we have always this kind of problem in the malleolus region because for 2 simple reasons, because the patient is still ischemic, and then there is a sort of venous hypertension that we create with hypertension, with the arterialization. So we have the failure of the skin approach, and we have the exposition of a Viaban or the thrombosis of the graft. And this patient, in some of this patient, we was constrained to do a limb amputation. So we modify our approach. This is a patient with rest pain, gangrene, and phlegmon of the foot, the progression of the necrosis. We do the debridement in the operatory theater, and then we carry on the arterialization with the monassess. This is an assess on the popliteal below the knee. We prepare the popliteal artery, we prepare the great saphenous vein. We destroy the valve with a mechanical procedure with the needle and infusion of saline solution. After that, we do the proximal anastomosis, and through an anterograde approach, we check the run-in, we check the graft, and Roberto do the endo treatment of the residual valve with a double wire technique. And this is the final result with a monassess on the popliteal below the knee. This is the foot, and this is the patient after the day after the procedure. He stand up and he can walk. In this kind of situation, there is some pro to the procedure because the patient wake up early, the patient can walk, we can reduce the hypertension in the Lejar sole, we can reduce the swallow of the foot and the leg. So we improve the nutrition of the tissue. And remember that after the arterialization, we must modify also the foot surgery. We must wait for the swelling. We must wait for the expansion of the arterialized network. We must respect the arterialized circuit and respect the forefoot cross. And remember that after the arterialization, I told you before, the foot is still ischemic. And we must adopt a tension-free surgery to avoid focal ischemia. So we adopt a guillotine technique, use of dermal substitute, use of the skin graft, or subdermal suture. In conclusion, arterialization is a complex crossword puzzle. We clarify the proper criteria of the patient selection, the proper time of the procedure, but we must well clarify the true pathophysiology of the vascular system remodeling. Thank you.
Thank you very much. Thank you very much for this impressive presentation. With
Amazing.
this, yes. This could be a really another chance, another useful chance for CLI patient and for patient normally destinated to a major amputation. So for sure, these procedures may give new perspective for this situation, extreme situation. I don't know. I have so many questions, but I would like to see from attendees, from people connected, some questions waiting.
Well, there are no questions still, no yet, but probably they are preparing someone. In the meantime, I think Andrea centered the point with the patient selection that is very important since DVI was created and proposed like an alternative. Many people with no skills to recanalize the arteries start to create DVI in every patient. And I think this is not a good solution because, as you said, the patients need a specific surgery. We are going to, in some cases, create a different or new ischemia. Some patients are going to risk minor amputation, and even though some patients could risk a major amputation. So patient selection for DVI, I personally believe, is the most important point.
Yes,
I remember,
agree.
in fact, the case we did together with Andrea last year. He was here helping me to do an hybrid procedure, and it was a patient that a real no option, gangrene in the 4th and 5th, the gangrene in the 3rd, and I failed to do everything. Finally, we did the DVI. Luca Della Paola amputated the 4th and the 5th, do a Ethyrectomy in the 3rd, and even though was able to save the residual part of the foot, no transmetatarsal amputation, and we saw the patient 1.5 months ago, completely healed and stable with the pulse in the graft, perfect. So this is some strategy with amazing result, but the indication and the patient selection is very, very important.
So guys, there is a question from the audience for Andrea, of course. Thank you for the impressive work. Please, how long do you wait before determining whether DVA has worked or not? How do you monitor progresses? TCPO2, something else, clinical?
Thank you for the question. First of all, the clinical situation. The TCPO2 is growing impressionant because after the arterialization, after 1 week, you can observe a growing up of the TCPO2, for example, from 2 or 3 millimeters to 45, but it's due also for the venous hypertension that you create in the foot. So The clinical is the best way that we can carry on the follow-up on this patient. The pain, because after the arterialization, the first result is the resolution of the rest pain, because the pain receptor are in the venular system. So the arterialization solve the rest pain. Consider that after 3 or 4 weeks, in some patients, we observe the thrombosis of the graft, so the failure of the procedure, but the patient didn't develop a recurrence of critical limb ischemia. And because 1 month, 3 weeks, 4 weeks, 1 month are enough to wake up a sort of micro shunt that are sleeping in this foot. So the clinical status of the patient and the TCPO2 is important, in my opinion, for what concern the foot surgery indication.
Yeah, I fully agree
Okay.
with you. Clinical aspect, clinical evolution. What we have been seeing with Luca in our very small experience is that the clinical situation is very, very clear. The last DVI I did, it was everything percutaneous in a 32 years old lady with Burger disease. The only option was a DVI. I finished in the vein, so I decided to open that. It's functioning pretty well. When the DVI was occluded, the only residual toe, that was the third toe, was ischemic again. So Luca sent the lady to me again. I opened the DVI again, and she was ready to amputate the third toe. And finally, she maintained it. He maintained it. Luca was able to maintain the toe because after the DVI was open, the flow was patterned, the flow was present, and the aspect of the foot, of the forefoot, changed clearly after 2 hours.
Correct.
There are two more questions. The first is, do you perform ligation of the great saphenous vein after arterialization?
At the beginning of our experience, yes, we do the ligation of all the collateral of the great saphenous vein in the leg. Now with the monoaccess procedure, we prefer to use the coiling embolization because we want to reduce at the minimum the incision of the skin, because the patient is ischemic. So if we reduce the skin incision, we reduce the possibility of the failure of the skin incision itself. So now we prefer to do the coiling embolization of the great saphenous vein collateral in the leg.
Okay, so directly linked to this this answer, there is how to. Oh yes, there is another one. Please clarify, how do you avoid breakdown of the distal wound working in a edematous tissue?
What we do to avoid the edema in this patient is to divide the embolization of the big collateral stealing the blood flow. So we create in the first approach a primary embolization. So we want to have a much more direct blood flow in the foot. But what we observe in this kind of patient, that after the arterialization, we have a reduction of the edema of the foot. Why? Because the transmural pressure in the vein is not directly correlated to the improvement of the blood velocity in the vein itself. So during the arterialization, at the beginning, we think now we treat a patient with rest pain with edema because they sleep when the foot down on the bed. After the arterialization, we have a balloon as a foot. But what we observe is that after the arterialization, we have a reduction of the edema because we we do a primary closure of the collateral of the foot, and the resolution of the rest pain with the patient with a complete resolution of the rest pain allow the reduction of the edema. And then in some patients, we use elastic socks or elastic bandage of the foot itself to reduce the edema before surgery.
Okay, thank you. The last two questions, and we have to finish. How do you decide which collateral vein branches to embolize or ligate after DVA?
I think the question is about the collateral and the branch in the foot. We decided to ligate or embolize better the collateral that are going in the, for example, in the deep dorsal vein. So we reduce the hypertension in the anterior tibial vein, and we reduce and embolize the collateral that are the runoff on the posterior tibial vein. So we create a sort of the direct blood flow in the foot.
Perfect. Redirect. And the last one, great work. Are venous branches always requiring embolization? And is there a specific size vein needed?
No. There is not a specific size. It's only the view that you have after the arterialization, the vein that still in the blood flow in the other route, you have to embolize. The other you leave, because in some vein are the exit from our fortress. So we must close only the vein that are specific, the outflow vein.
Perfect. So
Very clear.
Very, very amazing work, and thank you very much to let us learn, watching and listening to your great experience. You and Roberto are really so nice guys, and we are so proud to have you in our Click team. Thank you very much to Mariano for the always amazing cases, and to George, who is not here still with us, but I think this session number 4 was really amazing, and I'm telling you, have a nice evening, and thank you to all the sponsors, so Shockwave and Stealth 360 and Imity and OneView and
Everyone.
Sorry if I missed somebody. Thank you very much again, and
Thank
see
you
you
to you,
soon.
Marco.
Thank you,
Thank you to you to be an excellent moderator as always. Thank you, Andrea and George. Thank you to everyone to join us.
Goodbye.
Bye.
See you the next time. Bye, guys. Thank you.
Bye.